Well, it's on the hour, so I think we could go ahead and get started. So I'd like to remind everyone to mute their microphones until you'd like to talk, to limit the background noise, and also if you have headphones handy, that's also helpful. And please feel free to use the chat function on the right if you're joining us online at any point if you'd like to comment or if you have a question during the presentation. All right, so I'd like to welcome you all to the second ever Radvocacy Journal Club, which is meant to help ACR members become more familiar with important issues in health policy and advocacy. This journal club is titled Show Me the Money, and we'll try to shed some light on recent legislative developments on surprise billing since we discussed it last fall, as well as discussing price transparency in the context of some recent news on the regulatory side. I'd like to mention some of the people who've been instrumental in making this possible, many of whom you'll be hearing from at some point today. Dr. Humans, the chair of the Radiology Advocacy Network, Dr. Amy Patel, who wears more hats at the ACR than I could possibly name. Eugenia Brandt, she's our Director of State Affairs over at the Government Relations Office. Rebecca Spangler, Director of Congressional Affairs. Michael Peters, Director of Legislative and Regulatory Affairs, and Melody Ballesteros, Assistant Director over at GR. So as I've mentioned, this will be a two-parter. To begin, we'll give an update to surprise billing since we last discussed it in September. And then we'll transition into a topic that's very much related to surprise billing, which is price transparency. I'll introduce each topic. We'll hear from the ACR GR staff who are working on these issues on our behalf. And then we'll have opportunities for discussion following each topic. So for those of you who weren't able to make our last journal club, I'll try to hit the salient points on what surprise billing is, why we should care, and what the general approaches have been to try to mitigate it. So surprise billing occurs when patients are treated by providers outside of their health plan's network under circumstances that the patients can't reasonably avoid. So a common scenario might be a patient who goes in for an elective surgery from an in-network surgeon and an in-network hospital, but are surprised to learn afterward that their anesthesiologist, radiologist, or pathologist are actually out of network. Another common scenario is emergency medicine, when patients have little to no choice as far as whether they're taken to an in-network hospital or an out-of-network hospital. So why does surprise billing occur? So as many of you know, in-network providers negotiate a discounted reimbursement rate with health plans to the patients that are covered under that health plan. And then it follows that out-of-network patients get charged with a higher out-of-network rate. So when that occurs, three things happen at once that that lead to a surprise bill. The out-of-network provider will bill the patient at a higher rate. The plan then covers a smaller proportion of that rate, and then patients are left to pay the difference, which is how the other name for surprise billing gets its name, which is balance billing. So to give everyone an idea of the prevalence of surprise billing, nearly 1 in 5 inpatient admissions includes a claim from an out-of-network provider, which is that first column here on the left. And to a lesser degree, it also occurs in the outpatient setting. And patients may still face surprise bills when using an in-network facility. So the second column shows that 15% of admissions that occur in an in-network facility also incur a surprise bill, which is almost as high as the number for inpatient admissions in general. And as I've mentioned, emergency room visits are particularly prone to surprise billing. In this first bar graph, we see that emergency room admissions with an emergency room claim are twice as likely to incur a surprise bill than those without an emergency room claim. That first blue bar is almost 30%. So briefly, I'll just go over some general approaches to mitigate surprise billing. One is to prohibit providers from billing patients for the balance at all. The idea being that patients shouldn't be held liable for services that they couldn't reasonably identify as out of network. Of course, there are issues with this regarding the right of the provider in this situation. It may reduce the leverage of the provider in negotiating with health plans if they aren't able to charge that higher out-of-network rate. And ultimately, it discourages providers from staying out of network. Another approach is to notify patients ahead of time. The notification needs to happen, obviously early enough so that the patient has a chance to make that decision. Ideally, it would include an estimation of costs between in-network and out-of-network providers, and also provide direction on how to select an in-network provider. Patient notification in general is a limited approach because surprise billing often happens in situations where notification isn't possible, such as in the emergency room. A fair payment rate should also be determined. The idea here is that a rate should be determined between the provider and the health plan far before the patient ever needs the service. It's important to protect the patient in this scenario. And as far as how this rate should be determined is a few approaches have been suggested, such as a baseball-style arbitration process where an independent mediator kind of mediates the negotiation between the provider and the health plan until a quote-unquote fair rate is determined. You could also tie rates to a percentage of Medicare rates. And if that seems like too broad of an approach, an average of the in-network rates in the region could be used. Now, price transparency is a key here to actually just find out what those in-network rates are. And ultimately, just as a side note, provider charges may be unreliable as a benchmark, as these are often very high and not totally privy to market forces. And the last couple things, obviously narrow networks contributes to this problem. We have increasingly narrow networks in the name of offering a cheaper plan, but if you have a narrow network, it increases the chance that you get care from an out-of-network provider and that a surprise bill will be incurred. And lastly, a federal solution may be needed in adjunct to state solutions. And because of the Employee Retirement Income Security Act, or ERISA, which precludes states from regulating self-insured health plans, which cover half of privately insured Americans. So at this point, I'd like to bring in Eugenia Brandt, the Director of State Affairs, for our state-level legislative update.
It would be good if I unmuted myself. Good evening. My name is Eugenia Brandt, and I do not have any financial disclosures. And the good part about this issue, or rather the good and the bad, is it does affect more than just radiology. We find at the state level that there are a lot of impacted parties. So in addition to us, there are ER physicians, anesthesiologists, pathologists, plastic surgeons, regular surgeons, basically anybody who may find themselves in a hospital setting that ends up either having direct interaction with the patient, or in the case of pathology, there's not always, or radiology, patient facing, but we do end up being pulled into the larger debate of the out of network legislation and basically states stepping in to try to do rate setting. And the out of network care is usually solved with balance billing, and Mike did an excellent job outlining that. So for ER physicians, there are different factors that play into it, such as EMTALA. With radiology, arguably another factor for us is prior authorization, whereas for an ER service, a patient may present into the ER and have some imaging done. But for scheduled services, oftentimes prior authorization requirements kick in. So it's more difficult to run up a high imaging tab, because oftentimes the who's going to pay for it gets hushed out on the front end. And this is just a slide that I've prepared on states with out-of-network and surprise billing type bills. This is just of April, and there are as many as 26 states that are looking into it. And that's not to say that they're still looking into it. There are some states that have already wrapped up, or we know the bills are for sure dead. But the darker the color in this graph or in this photo, the more bills there are. So oftentimes there will be multiple bills filed. So in addition to having a House and a Senate side bill, some states will have multiple sponsors introducing different types of bills trying to solve, quotation marks for solve, this problem in various ways. So there may be a transparency bill, there may be a bill that calls for arbitration, there may be a bill with sort of the insurance language on reimbursement, and there may be a bill that's more palatable for physicians. So, for addressing these issues at the state level, we've really found that keeping a united front is helpful because when we band together as specialties, one of the things that helps us is, first of all, we can come to the state medical society and we can say, look, we know that a large part of your membership is internal medicine primary care physicians. However, because it impacts so many specialties, we really want you to step in and be a player. So, for please don't be on the sidelines for this. These specialties are united, and we want the state medical society to weigh in and represent us. And so we have a lot of meetings where we band together, we hold hands as much as possible, we try to find a common ground, and we can push back on the really bad proposals. And for many of the lobbyists and the staff and the chapter leaders, that is helpful because we can make the introductions between our various chapters, we can share and compare intel, because oftentimes things are happening very quickly. So even though I have spoken to the lobbyist maybe a couple of days ago, there was another meeting, and maybe lobbyists have had a chance to have sort of a sidebar conversation after a different meeting. And it's nice for me to keep a pulse on what's going on. And also for group communications, letters, briefings, articles, anything that can be helpful, that illustrates our point better, anything that refutes some of the information, maybe that may be more pro insurance lobby, and we can bring something that sort of highlights our position a bit more. It's very nice to share those resources and to help our respective chapters. And the strength in numbers is certainly there. When the AMA went to work on a letter bringing specialties together, because some of the work had already been done on the state level, we were already working on this issue, and it was really nice to have people be at the table and sort of have an open discussion as various specialties on what we can do together. So, still from last fall, many more states are in session now, of course, but the consumers are still aligned with insurers. And this has been a very maddening aspect of this issue, is that consumers feel that they have somehow been wronged by the physicians because the physicians are the ones sending the bill. So the consumers are approaching the state lawmakers and they want an outright ban on balance billing. And they are not really interested in how and how much the physicians are getting paid or what balance billing represents to contract negotiations. All they know is they want to be out of it. They don't want to be, so to speak, in the middle. So the lawmakers are very aware of that pressure from the consumer side to do something about it. And there are various states that have some form of balance billing restrictions already in place. But for example, in the case of Texas, there is an arrangement now where there's a threshold. So for bills that are over $500 from providers or facilities, the patients can initiate mediation. And in the years prior, it was just the bills from providers, but last year they've modified the statute to include facilities. So that caused an influx of balance bills that were now eligible for mediation. And the department basically was swelling up with complaints from the consumers. So there was a lot of bad press about mediation is not working, whereas the department really did beef up its workforce, and they hired additional people to do the mediation. So it was just, in terms of the law being a fairly new modification that's brought in these extra cases. So the patients are not often aware of these nuances. So a lot of patient education has to continue, and there's very much a need for the change of narrative. The physicians cannot be the bad actors, or we cannot be portrayed as holding the physician hostage somehow. Um, part of part of the business of medicine are these types of issues, but unfortunately, the media picks up on these very grotesque bills, and then oftentimes it's very difficult to be on the receiving end of the criticisms and we're often playing sort of defense with the messaging. But as we know, there's an issue with network adequacy and transparency of healthcare pricing, which is going to get talked about a little bit more later. But because Mike has covered the minimum standard benchmarking proposals, which are percentages of Medicare, or benchmarking to in-network payment, or the greater of 3% of allowable, which is the one often favored by insurers, or no benchmarking specified. How does radiology overall feel about not having benchmarking specified, but instead having an alternative dispute resolution in place? So mediation or binding arbitration, and then not having a benchmark for payment be established. That is one scenario where potentially the physicians can do fairly well, because to avoid something like a benchmark to Medicare or benchmark to in-network payment, which represents discounts that someone else has accepted for volume and less administrative burden, um, there is mediation or arbitration, and that gets talked about on the back end versus there is a negative benchmarking in statute somewhere. And of course, we still provide resources, the ACR staff, your chapter, your state medical society. I know some of our members are very well plugged into the state medical society membership and leadership. And there's a player it's a new 501c3, relatively new, but Physicians for Fair Coverage. They offer many resources, and I'm including the link. And Texas, because this issue has been percolating for a while in Texas, they have a white paper on it. But just to go back to the slide, I mean, this issue it's not going away, and regardless of how good or bad the laws are at the state level, the ERISA plans that are not subject to the state regulation still have to be addressed. So that is why we're seeing so much interest at the federal level. And just for future discussion, states with transparency type bills, just the difference between there's less talk about transparency, and out of network is very much the buzzy issue that we get to discuss. So thank you very much for this opportunity, and I'll turn it over to our next presenter.
Yeah, thank you, Eugenia. Yeah, we can definitely send out those resources you mentioned at the end to everyone who's in attendance today. And yeah, let's, Rebecca, whenever you're ready, we can go ahead and proceed with the congressional update.
Thank you. I'm trying to figure this out. Please hold. Mel's here just in case I need backup, but wait. I got it. Can you guys see that?
Yes, it's going. Yep.
Oh, okay.
We're
very
good.
proud of myself. So again, my name is Rebecca Spangler. I am one of the directors of federal affairs here at the American College of Radiology. And I'm going to talk about our federal advocacy efforts surrounding surprise medical bills. Like Eugenia, I have nothing to disclose. So a lot of what I'm going to talk about is kind of duplicative from what Yuji mentioned. Really, it's the media reports that have brought this issue to the attention of Congress and the administration, for better or worse. There's been a lot of news out there. Vox.com, for instance, has done a whole series on surprise Bills, the Boston Globe, NBC Nightly News, and honestly, none of these stories make doctors look really good at all, especially since the bills from out of network physicians can seem particularly egregious. For instance, there was a local story here in the DC area where a woman's son took a ball to the face in lacrosse practice. She took him to the hospital. He needed his nose adjusted. The plastic surgeon that they called in was out of network, and all of a sudden, she has a $23,000 bill for a kid's nose. So it's really those kind of egregious examples that are getting the attention of the media and then therefore getting the attention of, like I said, both Congress and the administration. So primary jurisdiction on this issue in Congress lies with, on the House side, the Energy and Commerce Committee, and then the Education and Labor Committee because of ERISA. And then on the Senate side, it's the Senate Health, Education, Labor, and Pensions Committee, better known as HELP. Secondary jurisdiction falls to the House Ways and Means Committee and the Senate Finance Committee. There would have to be kind of some legislative tweaks, but we expect to give them equal jurisdiction to Energy and Commerce, Ed and Labor, and Health. But we do expect that because this issue is getting so much attention, they will at a very minimum, at the very least, want to hold hearings so they can kind of put their stamp on things and get involved. So Senator Cassidy from Louisiana, who's a GI doc, has kind of been leading the legislative efforts. So he and 5 other bipartisan senators have formed a working group to propose solutions. And this is the same working group that Yuji referenced earlier, I believe, in her presentation. They were together last Congress as well. And that legislation from previous Congress that was supported by the working group, again, included that payments for out-of-network services be paid in accordance with applicable state law, and then if no state law exists, reimbursement would be benchmarked to 125% of average allowed. That legislation didn't pass Congress, and it has yet to be reintroduced. But we do suspect that the work group will reintroduce something in the very near future. In the meantime, you have Senator Lamar Alexander, who's the chairman of the HELP committee, kind of really starting to look into surprise billing and solving the issue of surprise billing as part of his overall kind of increasing transparency effort in the healthcare system. And he's retiring at the end of this term. So he really sees this as a legacy issue. So we expect that he will want to put his stamp on whatever Congress winds up doing with this. HELP so far has had member-only briefings, but we know that hearings are forthcoming, most likely at some point next month. But it's really unclear right now if the working group and the committee are on the same wavelength. No one's really sure if Cassidy's driving the train or if Alexander's driving the train here. So it'll be interesting to see how that plays out. The House Education and Labor Health Subcommittee held a hearing on April 2nd. So no physician organizations were asked to appear, and the witnesses were representatives from Families USA, Brookings, Georgetown University Health Policy Institute, and the American Benefits Council. That was not physician friendly, to say the very least. I mean, the nicest way I've been able to put it when I've been talking to members of Congress and staffers about this is that the whole thing was offensively atrocious. The witnesses all agreed that the patient had to be protected from surprise bills, but there was really no mention of network adequacy at all. Like no negative talk about any kind of insurer issue or wrongdoing that might be happening here. So ACR, as well as our AMA and hospital-based physician colleagues, we also support taking the patient out of the middle. And then along that's kind of everyone's primary goal at this point. It's the primary goal of Congress, and it's the primary goal of the physicians. And I do think that, and the hospitals, I think the insurance companies would probably say that's their primary goal as well, but I don't know if I necessarily believe that. But what we are supporting, along with, as Yuji mentioned, kind of the larger working group of the AMA and the physician specialty, the impacted hospital-based physician specialty organizations, both on the national level and on the state level, is ensure accountability through robust networks. limits on patient responsibility. We feel like patients should only be responsible for in-network cost-sharing rates. Transparency. Patients who have scheduled care should be informed before the day of about any anticipated out-of-pocket costs. If we do have to set benchmarks, we don't necessarily love the idea of basing them on Medicare rates. We'd prefer a more of an independent database. And then alternative dispute resolution, so mediation or ADR should be provided for extraordinary circumstances, complex conditions, special expertise, and a variety of comorbidities that may impact the patient's care. And that's all I have.
All right. Awesome. Thank you, Rebecca, for that excellent update.
Hold on, I'm trying.
All right. So at this point, I want to open it up to discussion for those of you on the Hangout or on the call. We mentioned some of these expectations, these new expectations on providers. So, for those of you in practice, what might be your approach to adapting to some of the proposed solutions? For example, if you were prohibited entirely from charging the out-of-network rate, would it affect your leverage in negotiating in-network rates? And perhaps would it affect your bottom line? And lastly, what do you think is the best way to determine a fair payment rate between providers and insurers? So the questions you see up on the screen are just meant to spark discussion. We can address these if you have thoughts, or address none of them. But please, if you have a comment or a question, feel free to go ahead. All right, we'll give it a few more moments. Does anyone have anything to add? Okay. All righty. Well, if we can come back to this topic. If you think of something at the end, we'll have another chance for everyone to discuss the next topic, price transparency. And if you have a surprise billing related topic, we can address that at that time as well. All right. So at this point, we could move on to our discussion of price transparency. And so we've touched on price transparency a bit in the context of surprise billing. I mean, it's definitely a huge factor in mitigating surprise billing. But it's also an important and timely topic in its own right, given some developments on the regulatory side recently. So to give some background on this topic of price transparency, currently we have incredibly opaque and complex pricing practices, which lead to decreased pricing efficiency, where healthcare costs are not really subject to market forces at all. And patients have incredible difficulty planning for healthcare costs or comparing healthcare costs between providers, or attempting to decrease their healthcare costs. And currently, there's no viable way to compare quality relative to price as well. The need for price transparency is particularly urgent at this time when patients are experiencing increasing out-of-pocket healthcare costs, with increasing prevalence of high deductible healthcare plans and narrow networks contributing to this problem of surprise billing. All right, so what are the challenges to price transparency? One is quality. So obviously nobody wants low cost, low quality care. And so any attempt at making pricing data more available to patients needs to deal with this problem of how to assess quality and present quality data to patients. A second issue is the complexity of data. Which prices do we make public, and how do we make this data relevant to a patient's medical decision-making process? Is it the out-of-network rate, the in-network rate, the likely out-of-pocket cost for a patient? I mean, these are all important questions that I think Michael Peters will discuss a little bit more in coming up. And lastly, this data is decentralized, and the question of how to procure and compile this data is a huge one. I mean, how do we get this data from hospitals, providers, insurers, and pharmacies on a national scale? So I wanted to touch on some recent executive actions from the Trump administration. It always piques my interest when I see this come up in the news. And so and I'm sure many of you have at least heard of some of these new developments as well. Over the new year, the Trump administration published a rule requiring hospitals to publish their standard charges on the internet in a quote, machine readable format. And from what I understand, there's been varying compliance on this issue. I think one hospital system, Sutter Health, did publish their charge master list, but in this data science language that's incomprehensible to a normal human. So they kind of took that machine readable thing literally, which doesn't seem particularly helpful to me. Later that month, the Trump administration sought to eliminate a legal provision that allows pharmacy benefit managers, or PBMs, to negotiate rebates. So currently, the practice is that PBMs can receive rebates or kickbacks to have more favorable coverage of a particular drug under a given health plan, which is a practice that's kind of increasing in its use, and it's also very expensive. And a few weeks ago, the Trump administration moved ahead with the proposal to require drug companies to disclose drug prices on drug commercials, which obviously has gotten a huge amount of pushback from the pharmaceutical industry. But interestingly, I've heard of at least one drug, Xarelto, an anticoagulant, who's tried to get ahead of these regulations by actually giving the likely out-of-pocket cost of the drug in their television commercials. So I think it's, at the very least, it's a very interesting idea. All right, so at this point, I'd like to throw it to Michael Peters, the Director of Legislative and Regulatory Affairs at the GR office, for an update.
Great. Is there a way to get my slides up, or?
Please.
It's all right if not. Well, I can just sort of go from what I have in front of me. So I just wanted to quickly update the group about some price data transparency proposals that are sort of in the works right now as part of other larger rulemakings. There are two Cures interoperability related rulemakings right now, and Cures is the 21st Century Cures legislation passed in late 2016. It was kind of a Christmas tree rulemaking addressing all kinds of issues. Oh, there we go. I'll hold for just a second for Melody.
Oh. So I've actually pulled up, this is Mike, I've actually pulled up your presentation, but if Mel wants to take over at any point, that's fine too.
Great, so if you could just go to the second slide.
Okay.
So there's two major rulemakings out right now that would implement various provisions of Cures. They're primarily focused on interoperability and trusted exchange, but there are provisions in there that relate to the pricing transparency issue. The CMS proposed rule deals with requirements for certain payers to make enrollees electronic health information held by that plan available through an open API. And the ONC's proposed rule deals with a whole bunch of different issues, including standards for APIs, health IT certification changes, which primarily would impact EHR technology, and key aspects of an information blocking prohibition, which actually came from ACR endorsed legislation. We'll talk in a second about how that relates to this session. So next slide, please. So the Cures proposed rule, the types of data that payers would need to make available via open APIs would be adjudicated claims, including cost, encounters with capitated providers, provider remittances, enrollee cost sharing, clinical data, which I won't go into on this session, and provider directory, which is also obviously relevant to the surprise billing issue. because the idea is that enrollees would be able to check to see use a network relatively easy on their payphones via the Open API and formularies. So next slide, please. ONC's proposed rule, as I said before, it deals with a whole bunch of different issues that I won't go into, but right now I'd like to focus on the information blocking provision piece, which is arguably the most important. Information blocking is a practice likely to interfere with, prevent, or materially discourage access, exchange, or use of what they call electronic health information. And electronic health information is actually broader than what we're used to in things like working with electronic health record technology, et cetera. Electronic health information actually is electronic protected health information under HIPAA and any other information that is transmitted by or maintained in electronic media that identifies the individual or can be reasonably used to identify the individual. So de-identified information is not part of this, and relates to the health or condition, provision of care to, or the payment of provision of care to an individual. So there's the cost issue popping up there as well. Within ONC's proposed rule, it also includes a series of questions. Now, these aren't proposals currently. What ONC plans to do is initiate a rulemaking in the future that might address some of these issues and incorporate this kind of data into the electronic health information definition. And once it does that, that information would be subject to the information blocking provision. So this is all about making price data accessible. I won't go into these questions. I just sort of included these here. You could scroll through the next series of slides till the end that contain some of the questions from the RFI. What I would like to ask this group is, if you have thoughts about these questions, to please connect with me within the next couple of weeks and provide input, because actually ACR is in the process right now of working with our relevant commissions and committees to develop comments in response to these two proposed rules, including the ONC's RFI on price data transparency. And next slide, please. And the idea is, we're currently in the proposed rule period of time. After CMS and ONC receive comments on the proposed rules, they'll probably implement final rules in the fall 2019 timeframe. CMS may finalize the payer plan requirements that we discussed before, depending on public comments, but the RFI questions that we just went through from ONC are not going to be in their final rule. Again, those were just asked for the purpose of generating public input on the questions, and that will be dealt with via a separate rulemaking in the future. And that is all I have for now.
Awesome. Thank you, Michael. I'll bring up some of my discussion questions. As Michael mentioned, an important question is which pricing data should be presented to patients in the name of price transparency. And who knows? Maybe what you say here might make it into what the ACR eventually ends up commenting on this proposal. There's a few other questions there. Again, these are just meant to spark discussion. We can address all or none of these, or any comment or question you may have at all about this subject. But there are questions that affect radiology in regard to price transparency in general, like would you be open to publishing your charges from your practice online? What might be the pros and cons of that? And what quality metrics about imaging services do you think we should provide to patients and physicians to aid their medical decision-making process? So I'd like to open it up to anybody at all who'd like to make a comment on this or the prior topic.
This is Howard Fleischon. Michael Peters, if you would, the whole idea of price transparency, especially with hospitals, is a confusing one. I mean, just anybody who's been to a hospital and received any kind of bill the pricing that they received and the pricing they end up actually responsible for are very, very different. It's variable from hospital to hospital, from provider to provider, from patient to patient. Even if the charge masters are published, how is the public supposed to really digest what they're responsible for, do comparisons, or how are they really supposed to digest this information? Healthcare is so complicated, especially pricing of healthcare. It seems like a very daunting task, and if we don't simplify it, if we don't create some standards, it seems like it'll just be an exercise in futility.
Yeah, I think I would have to agree with that for sure. One of the things that's important to understand about these proposals, particularly the CMS one on payers and the type of information they make available, the idea is to make it available via open APIs that then third-party apps would come in and provide that information to the enrollees via, their interfaces. So the idea is that, this would create a market in a sense for mobile apps to make this digest the information that's made available via the APIs and show them to the patients in ways that are engaging or simplified or more understandable than just, say, posting it on the internet.
Thank you.
And I should also point out the ONC's information blocking provision. That deals more with the type of data that would be, shareable not only with patients, but also with other providers too. So dealing with data sets that are moving from EHR to EHR to PHR to app, a whole bunch of different exchange scenarios would be covered by the information blocking provision. So different ways to address similar problems.
This is Yuji. If I may add just a little bit towards to the point where the consumers are getting into the game, because some of the proposals that I'm seeing, they're so-called right to shop bills, and they are proposals to establish shared savings arrangements where a potentially savvy consumer can get cash back or gift cards if they are able to find a cheaper service, thus saving their insurer money, and the insurer will then reimburse the difference in some manner or percent of difference. And these bills are popping up. I've seen them in at least 4 states, and they're to establish internet programs where this information has to be published in some form of standardized manner to allow the consumers to shop for healthcare the same way they shop for toothbrushes on Amazon. And it's really not only obviously our specialty, but many physicians are alarmed by such proposals because it is possibly discounting the impact of quality matrix that should be incorporated into the decision making. And it's very difficult to argue against patient being well informed and educated, but then patients are obviously in charge of their own healthcare, but then shopping for healthcare without having all of the information, especially quality information, is potentially dangerous.
And then this is Rebecca. I'll just add, if I may, onto that I think kind of from the political conspiracy world that I seem to exist in these days, that I think a lot of the hospital associations will tell you that, especially with the charge master and the transparency surrounding that information, I think they feel it's a setup and it is kind of a step towards what is ultimately going to be a site neutral policy.
Yeah, I think those are
So
both. Please
So
go ahead.
Rebecca, I'm sorry. Rebecca, this is Howard again. So when you say site neutral policy,
Mhm.
you're talking about a Maryland type situation where everything is paid at a given rate, or you're not referring to site neutral as far as hospital facilities versus non facilities.
Yes, hospital facilities versus fee schedule, hospital facilities versus non-hospital facilities. I think that again, it's from what I've heard, the rumblings is that this is something that those in the hospital world are concerned because they know when they put those charge masters up there that it isn't data that anybody can really interpret, and they're not necessarily real numbers. And we all understand that because there's a difference between cost and charge, but obviously consumers don't. So I think they're concerned it's the administration's way of kind of broadcasting that ridiculousness so that they will then be able to come in and fix it by kind of equalizing the payment system.
Okay.
Right. I think that speaks to the broader point of the ultimate goal of price transparency, which is to bring the hospital charges and the provider charges more in line with reality. I think that would ultimately be the hope, that it could be less positively skewed as price transparency increases and kind of hem in the outliers. But obviously we're a long way from that, and there's, as Eugenia touched on, there are huge questions to answer based on how we assess quality, how we present quality data, because without the quality side, these numbers have even less meaning than they already do. Do you have anyone else that would like to make a comment or question? All righty. Hearing none, I think I'd like to thank everybody for joining the Hangout or joining the call. I hope this was very helpful. Thank you again to all the speakers. I felt this went swimmingly, so thanks everybody, and we'll see you at the next Journal Club.
Thanks so much for having us.
Thank you.